My colleague Wazrana will now introduce our plenary speaker, Associate Professor Mythily Subramaniam.
Dr. Subramaniam received her PhD in Gambling Studies from Monash University and is currently Director of the Research Division and Lead Investigator of the Program of Mental Health Policy Studies at the Institute of Mental Health, Singapore. She is also a consultant with the Ministry of Health, Singapore. She has published over 250 articles in the area of well-being and mental health. Let us now welcome Dr. Subramaniam to the stage.
Good afternoon, everybody, and thank you so much for staying back to the end of the day. I would like to start by thanking the organizers of the committee for inviting me to be a part of this really amazing conference, as well as to present some of our work. My work is going to be a little bit different from what you have heard throughout the day. As I was introduced, I'm from the Institute of Mental Health, and so the focus is really going to be a lot with mental health. And I'm going to be presenting a lot of my work which was done in Singapore, so it's going to have a very local flavor. So a bit of conflict of interest declaration. The studies that I'm going to present to you have been funded by the Ministry of Health, Singapore. They have also been funded by Temasek Foundation as well as the National Medical Research Council of Singapore. So this is the Lancet report which just came out last month in October, in fact. The Lancet Commission on Global Mental Health and Sustainable Development. It was written by Dr. Vikram Patel along with his colleagues. And they recognized that there is a need to reframe mental health. And they talked about three broad guiding principles. And the first principle was expansion of the mental health focus. So typically we have focused on mental illness, not just in Singapore, but the world over. And the Lancet recognizes that it is no longer enough to have such a narrow focus. We have to talk about, or at least acknowledge, mental health. The second part is convergence. And what he talks about here is the fact that a lot of evidence comes today from biological or from the genetic area. But we all know that there is a tremendous amount of research from the social sciences arena which is related to mental health. But somehow these two pieces have never quite managed to talk to each other. And there is a need that we do synthesize this evidence if we want to understand mental illness and mental health better. The third, of course, is the fact, a recognition that mental health is a universal and a basic human right. But what they also understand is something that the morning speaker, the keynote speaker talked about, which is that we seem to have a little bit of confusion about the various words that we use in order to define mental health. So we tend to use the words positive mental health. People tend to use the words of quality of life. There's quite a bit about mental well-being. And of course, today we also heard about happiness. And so again, the Lancet proposes that we should at least try and define some of these concepts. If possible, we should try to distinguish them from each other. And so this is what they say. They say that mental health is an asset or a resource that enables positive states of well-being and provides the capability for people to achieve their full potential. And we have kind of focused on this definition of positive mental health. And well-being, again, this is what Lancet says, is that it incorporates two different things. One is the aspect of subjective satisfaction with life, the positive affect or the mood, which is more in line with the hedonic concept of well-being, feeling well. The other part, which again becomes important in the area that I work in, is meaningful functioning and human development, which is Aristotle's eudaimonic tradition, leading more to functioning well. Now, surprisingly, the Ministry of Health in Singapore was actually pretty forward-thinking. So way back in 2007, I don't know how many of you are aware of it, they actually came up with the first mental health blueprint in Singapore. This first mental health blueprint in Singapore was a collaborative effort between policymakers, between the clinicians who work in the field, as well as some of the researchers. And for the first time, they dared to say the aims of this mental health blueprint is to strengthen emotional resilience and mental well-being of Singaporeans. The other part of it, which I haven't written down, was about reducing the incidence and impact of mental illnesses in Singapore. So as part of this first mental health blueprint in Singapore, we at the Institute of Mental Health in the research division, we were charged with conducting the first Singapore mental health survey. Now, this mental health survey for the first time went on to establish the prevalence of various mental illnesses in Singapore, as well as some of the correlates of these mental illnesses. But then the other part of it is that we were also asked to develop an instrument to measure the mental health concurrently. For us, this was a huge paradigm shift, because where I come from is the Institute of Mental Health. And for all of those who don't know about it, it is the tertiary psychiatric institute in Singapore, which provides mental health care to, I would proudly say, people who are most severely mentally ill. And then suddenly we were talking about positive mental health. So it was a bit of a difficult thing for us to do. We also had people who criticized us for doing it, because they were like, you shouldn't be in this business of doing positive mental health. But I definitely feel that these are very interrelated things, and one needs to look at it across the spectrum. So we looked at, first of all, understanding this concept of positive mental health. And what we did was we looked at the work of Mary Jahoda, done way back in 1958. And she talked about 6 approaches which one could use in order to get mental health. The first is attitudes towards one's own self. So this is a complete understanding of one's own weaknesses and one's own strengths. And it refers to self-reliance as well as self-confidence. The second is growth, development, and self-actualization, a movement towards higher goals, maximizing your potential, maximizing your talent and abilities. Integration. Integration here refers to integration of your cognitive self so that you are able to resist stressors. Autonomy, we all know that. It is about freedom of choices. It is about independence. Perception of reality. Now that sounds a bit like a psychiatric term, but it is not. What she means here is that we should be empathetic. We should be able to understand the reality of another person's position in life, understand where they come from, and be empathetic towards them. Environmental mastery is about adjustment. It is about learning how to solve your problems efficiently. And so, however, again, I think I'm repeating the keynote speaker here when he talked about the fact that this is also said by Schwartz and Link, which is that what is viewed as good and functional is often dependent upon who is doing the viewing and what value hierarchy is being applied. Now, we know that positive mental health is going to differ across societies. Again, I've heard multiple speakers refer to it throughout the day. In a more individualistic society, this is going to be all about autonomy. It is about the freedom of choices, the freedom of the way you want to live your life. Whereas in a more collectivist society, this is going to be more about conformity and societal norms. So we were a bit reluctant to just take a definition from somewhere and apply it to Singapore. We also realized that it may vary across the social groups. Even within these two communities, it may vary by gender, again talked about today, social class, and importantly in Singapore, by ethnicity. And so we did just a quick environmental scan, and we thought, could we get away with just using an instrument which has been used elsewhere? But we were looking at instruments which had been used at a population level. And as I said, going back to the concept, we wanted both the feeling well aspect and the functioning well aspect. The first instrument, of course, we came across, and it was a big buzzword during those times, was the Gross National Happiness Index from Bhutan. Now, this was proposed by His Excellency, the King of Bhutan, and he actually said that gross national happiness is more important than gross domestic product. However, it is important to understand, and I didn't know that when I first started working in this field, that happiness, according to the Bhutanese concept, was just not subjective happiness, but it was more a holistic reflection of the general well-being of the Bhutanese population. It was very much a multidimensional instrument. It is actually a very complex instrument. It has 9 domains, and it has 33 clustered indicators. We did toy with adopting it, and this is what it looks like. So it has psychological well-being, it has health, where they talk about mental health and disability, time use, education, and what I really liked, cultural diversity and resilience. And here they talk about ability to speak the native language, cultural participation, and artistic skills. Good governance by the government, of course, community vitality, ecological diversity and resilience, and living standards. So based on this very complex index, they divided the population into 4 groups based on 3 cutoff criteria. So at one hand, you had people who were unhappy or narrowly happy, and at the other end, we had people who were extensively happy or deeply happy. And what I liked again about the Bhutanese government was they said, we should have now, it's just not a matter of developing an index or developing a questionnaire, but our policies should address this particular index. So they said that everything that they do in Bhutan should have, every policy should actually adopt a gross national happiness index view. It should have that lens. And what it meant by that was that every time in Bhutan they have a policy which is implemented, they think about not just one thing, but they think about how all the 9 domains are affected by these interventions. So a very holistic view. And at the same time, these policies have to move people from unhappy and narrowly happy progressively towards extensively happy and deeply happy, which is more about changing their state of happiness. This, of course, again, I think familiar to a lot of us who work in this field. This is about Key's work, Corey Key's work, which is about the dual continuum model framework. So again, Corey Key sees mental health as a spectrum. And his spectrum goes from maximum mental illness to minimal mental illness on one particular axis. And on the second axis, it is about minimal mental health to positive mental health. Now, what I liked about Corey's work for the first time, he said, the position of a person along one axis does not determine where he lies on the other axis. Now, what does that mean? It means that you may be mentally ill, but that doesn't mean that you don't have any mental health. If you have a mental illness, but if you have pretty good social support, and if you are able to cope with a lot of difficulties, fact is you may have good mental health. On the other hand, we may have no mental illness, but if we have very poor coping strategies, and what happens is we are met with an extremely adverse scenario, we may actually have very poor mental health. And so this was an instrument which was developed. It was much easier to do in Singapore setting, 14 items. It assesses emotional well-being, psychological well-being, and social functioning. And he classified respondents as flourishing, languishing, and moderate. So flourishing is someone who has high positive emotions, high positive functioning. Languishing is someone who has low positive emotions, low functioning, and moderate, which is somewhere in between. And in fact, now, over the years that I have been following his work, studies have found flourishing to be protective against all-cause mortality, suicidal behavior, and prediction of future depression risk. These are all very important outcomes for us. And so this is a study which was done in Canada, which kind of proved Corey's point. And what they did in Canada was they looked at both the prevalence of mental illnesses as well as the extent of mental health in the population of Canada. And you can see the bars here. The purple bar reflects any mental illness. The green bar is a reflection of depressive disorders. Purple bar is substance use disorders, and it's supposed to be a cyan-colored bar, but it's gray here, and that is anxiety disorders. Now, when you look at the mental health status of these people, yes, majority of them are languishing. They do have poor mental health. But look at the other end of the spectrum. You have a small group which is actually flourishing. Seems impossible to believe, but they seem to have pretty good mental health. And then you have, of course, a reasonable number of people in the moderate group. Keyes himself examined the data from US, and this was a panel survey done in 1995 and 2005, used exactly the same techniques, looked at the prevalence of mental illness, looked at the extent of mental wellness in them, if I may use the term, and what he found was gains in mental health decreased the odds, and losses of mental health increased the odds of the incidence of mental illness. So someone whose mental health improved from 1995 to 2005 actually had a better hope of not having a new mental illness emerge in them as compared to someone whose mental wellness declined in this period. We also know as psychiatrists that if one has a mental illness, unfortunately you are vulnerable to a future episode of a mental illness. But what they found was that while this held true in their panel survey, but what was even more important was those who were languishing, those who felt very low and functioned very low, they actually had, that was a bigger predictor of having a future mental illness. Now this opens up a very important area for us, which is the field of interventions. And so it raises the possibility that you could, for once, shift people from a languishing to a more flourishing spectrum and thereby decrease even the incidence of mental illnesses. So coming to the development of the positive mental health instrument in Singapore, we felt that mental health is a multidimensional construct. We felt it is important to assess how people function rather than just how they feel. And we also felt that the role of religiosity and spirituality were not included in many of the multidimensional instruments. We intuitively felt this could be important for an Asian society. And we also felt that if we are going to develop an instrument for Singapore, it should have some input from the population. So the need for qualitative work. And so we started, as we start for almost every other study, we started with a literature review. And so we did a narrative literature review with focus on Asian literature. I have colleagues who are very good in Chinese, and they had access to some databases. So we were also able to include articles from other languages here. So multiple databases looking over a period of about 13 years, and full text of about 250 articles were reviewed. And what we did in this narrative review was to identify concepts. We also looked at what were the definitions of this context according to the literature. And lastly, we looked at what are the instruments which are out there to measure these particular concepts. We then used a modified Delphi method. So what we did was 3 of us sat down independently. We categorized the concepts into what we thought were slightly bigger piles, and we did it on the basis of how synonymous these concepts were, and we also recorded our decisions for this. We then met together as a group, and then we came up with what we thought were some of the concepts of mental health. And my colleague, Janavi Vengankar, and I'm presenting most of her work here, she was the lead author. She actually came up with a concept map which looked something like this. Please don't look at it because I don't. The only thing that I tend to do is I look at the things that I've highlighted, which is that mental health is contributed by 3 things in overall based on literature: positive affect, satisfaction, and psychological well-being. We have heard this today throughout all the lectures and through all the sessions that I have attended, so we all know that. And then we decided to do some focus group discussions. So we did focus group discussions with 100 people in the community. We did the discussions in English, in Chinese, in Malay, and Tamil. We audio recorded the entire conversation. We transcribed it, and then we did pile sorting to identify key dimensions. And this is what we found was important in Singapore. Personal growth, and I'm sorry, it has got kind of cut off, and autonomy. She's a go-getter. She has the freedom to make choices about her future. She's very confident and can express her opinions freely. The second part was relationships. Not at all surprising that it came up. We value it. He has a very good support system. You need a family. When you are younger, you need parents. As you grow older, you need a spouse, you need a child, and that kind of bonding is necessary. Spiritual beliefs and practices. So someone said life is like a guitar strings. You can tighten it. You apply too much pressure, it snaps. What you need is balance. Meditation gives me that peace. Coping came up. Take your mind off things. Focus on what is positive. Think of solutions. And then what's really hung together, which we hadn't kind of bargained for, was personal characteristics, again mentioned by numerous speakers today. So positive things about the person, being an optimist, always looking at the bright side of things did come up. She's very positive, always feels good, things will eventually happen. What surprised us? Work did not come up. And I thought work would come up. I spent most of my life working. Unfortunately, why didn't it come up? But it didn't. It came up in terms of having a good working environment, more in terms of like interpersonal relationships. But it did come out like my work gives me meaning. That is why I exist. It adds positive mental health to me. Neither did it take away from it majorly. So, okay, that's good enough for me. Money didn't come up. Now, most people disbelieve me when I say that. Singaporeans said money didn't come up. No, it didn't come up. People didn't talk about it. They've said that we need money for like a basic amount of money. We do need that to meet our daily needs, our expenditure. But nobody actually said that money is the way that we would get or achieve positive mental health. That didn't come up. What is unique? Spirituality came up. This is something I have struggled with. I've struggled with it because policymakers don't quite like spirituality, surprisingly. A lot of them told me, can I take it out and would the scale still work? And I told them I can't, because honestly it hangs together. In multiple focus group discussions, there is a group of people there who state that religiosity and spirituality is important for them. Yes, there is also a group for whom it is not very important. I acknowledge that, but I can't take it away, because for them, this does provide a strong way by which they can achieve positive mental health. Need for solitude and personal space not mentioned. Nobody was surprised. We know what our HDB flats look like. We know how crowded we are. I mean, we can do without solitude and still have pretty good positive mental health. So this is how we defined it, and I'm very happy for you to criticize it, either here or later. We describe positive mental health as the ability to build and maintain relationships, possess coping skills, pursue personal growth and autonomy, and participate in religious and spiritual practices. Personality traits and characteristics such as being optimistic, open-minded, and witty play an important role in the individual's ability to achieve positive mental health, and they are closely associated with all other 4 domains of positive mental health. And we then decided to go ahead and make the instrument. So we adopted a pretty unique technique. We actually just used the focus group discussion transcripts to come out with our instrument. So this is really how we did it, because we were not very good at it then. And what we did was, so this is an excerpt from a focus group discussion. I think that Singaporeans need to be contented in what we have. Financially, we may not be great, but we need to enjoy life. If you get too ambitious, you'll be focusing on that part and not relax. We should be happy, spend time with family, be positive, and the person will become mentally healthy. And the items we generated were, I try to think positively, I enjoy life, I'm content with what I have, I try to relax, I try to spend time with my family, I spend time with my family. So very simple wording, very simple instrument, and we had 182 items from it. And I know the first speaker said, you know, 1 item can cut it. And I agree, it can cut it. But I think it wouldn't have cut it for my policymakers who wanted to see what could be tweaked. So definitely 182 items is a bit much. And so we did a lot of, we field tested it in about 2,000 Chinese, Malay, or Indian Singaporean residents. And yes, we use psychometric analysis to kind of shorten the scale so that by selecting items that best represented the construct of positive mental health for different age, gender, and ethnic group. A lot of work done by my very amazing biostatistician who did a differential item functioning to make sure that the items were kind of, they didn't perform differently. And so this is what we came up with. Very much as suspected, it was a multidimensional instrument with a higher order dimension of positive mental health, contributed by spirituality, personal growth and autonomy, emotional support, interpersonal skills, global affect, and general coping. So this 47-worded item questionnaire, this is what it looks like. We have it on a scale of 1 to 6, not at all like me to exactly like me. Total scores range from 1 to 6. 1 is a low and a 6 is a high. And so it goes like, I spend time with people I like, and they have to endorse how much it is like them. So what about studies after developing the instrument? So this is the first study we did in a population of 1,900 community dwelling respondents. We were interested in looking at correlates of this 47-item instrument. What stood out, I'm going to talk about age groups later, what stood out was ethnicity. And again, somewhat to my surprise, the non-Chinese ethnic groups, the Malays and the Indians actually had higher overall positive mental health. They also had higher PMH scores in each and every domain in this particular instrument. When we looked at gender, again has been talked about today, overall we found that females did have higher positive mental health scores. Emotional support was higher in females, no surprises. Spirituality was higher. I'm going to talk about age a little bit later because it's a bit complicated, but age groups also came up as a significant correlate. This is the work of one of my research officers, Rajeswari, and what she did was she wanted to see whether positive mental health actually there was some element of positive mental health in our patients. And as I said, these are patients with severe mental illnesses, so they are people with schizophrenia, with major depressive disorder, as well as severe anxiety disorders. And we looked at their positive mental health and we compared it to that of the population. Positive mental health was lower, and it was lower across all domains, except, again, going back to what has already been said today by the first speaker, we found that spirituality was actually the same. There was absolutely no difference in the spirituality scales between people with mental illness and the general population. Now, again, there are two explanations, as rightly pointed out. It could be that they are using spirituality as a tool to cope with their mental illness. But we also know that, unfortunately, for some groups, hyper-religiosity does become a problem with people with mental illness, but it wasn't a qualitative study, so I can't confirm or deny that. This is another study which is done by someone in my group, and what we did in this particular study was to look at whether positive mental health has really some relevance to our patients. And so we looked at the positive mental health in people with depression and anxiety, and I think what was important for me in this particular study is that we found that those who were hospitalized multiple times had actually lower scores in their general affect and in their personal growth and autonomy kind of domains. Those who were employed had higher scores on almost all domains except spirituality, and that is again a very important lesson for us. People with mental illnesses do not find a job easily, especially in Singapore. They have to declare that they have a mental illness. Finding a job is extremely difficult. Staying on the job is also no easier. And therefore, you can see that employment, on the other hand, has a huge positive effect on the mental health of these people. It is therefore going to even affect our resource utilization. And if you really want to put a dollar value to it, I haven't done it. But yes, mental health is going to help you save money, and therefore these people need to be employed for multiple different reasons. Life satisfaction was associated. General functioning of the people, which we assess with a particular scale, was also associated. And then since we had gone through our patients, we had gone through our population, what we had left was our staff. So we decided to do a study on our staff as well. And so what we did was we looked at the staff of the Institute of Mental Health, and we looked at doctors, nurses, allied health workers, and we wanted to see whether positive mental health was actually associated with job satisfaction. Unfortunately, single item, but what we did find was that job satisfaction was again significantly associated with total PMH. So yes, we have used it extensively. It's our scale, we would. But it is heartening that other people have also used our scale. And so the scale is copyrighted, but we don't charge for it. We give it to anybody who asks us for it. And we don't even ask for data sharing. So that is where we are currently. So locally, KTPH had asked for the use of the scale. They did some kind of a staff happiness project. Singapore General Hospital looked at it, and they looked at it in terms of burnout and job satisfaction. Because it's a multi-ethnic sample, we have had international requests. Closer home, Malaysia has used it in one of their studies. We had a Canadian group requesting for it because they wanted to do some outreach programs among Asians. And then we had Pakistan, which had also asked us for it. Interestingly, we had a study done in Puerto Rico. We request people, can you please send us the article once your study is published? We would like to know what's happening. Nobody does that. But the Puerto Ricans were very sweet. They sent us a Spanish version of the scale. So I found it quite interesting, and they actually published their work as well. So I do think there's a wider scope for the application of this particular instrument. And as I said, this is the summary of my various studies. We could identify certain groups which have either very high positive mental health, or we could identify certain groups which actually had lower positive mental health. And surprisingly, we found that as people grow older, other than emotional support, they seem to be actually doing pretty well on their positive mental health, with the overall levels of positive mental health being significantly higher than someone who was about 18 to 34 years old. So for every 10 years, it actually increased after that. As I said, we also found that it is not something which we have just dreamt of. It actually is associated with health outcomes. So it is associated with satisfaction with life, quality of life, health in general, and we have a negative correlation with depression severity and anxiety severity. So limitations, as I talked about it, all my studies are cross-sectional. Funding in this area, especially for me, is not very easy, so I tend to use smaller funds and we get these studies done. And so, of course, the causal relationships cannot be established. I completely acknowledge that. It's a 47-item instrument. Gets done fairly fast, 15 to 20 minutes. I have seen that it gets done because the wording is simple. But in a survey, people hate to use it because it really adds to the respondent burden. And so we are thinking about shortening it. And then one comes to this concept, which I have struggled with again, relevance of individual domains. So as I talked about it, spirituality is not something that everybody is going to identify with. So what happens if somebody scores 0 on the spirituality domain, but then has a score which is similar to someone who has some score on the spirituality domain, but scored lower on the other domains? Does it really affect their overall well-being? Is one person able to cope with life better than the other? Are outcomes for one person better than the other? This is something which I don't have data on currently. We also don't have any interventional studies to show whether the instrument is sensitive to change and also whether it really performs to inform further on that particular intervention. Now, for the future research directions, this is something which is happening globally, but I thought I would talk about it because our protocols aren't ready. This is the study which comes from Canada, which is called Flash on My Neighborhood. It's a very interesting study where, for the first time, Canada has decided that they are going to improve the positive mental health or well-being at a population level. So they decided to select 6 low socioeconomic group, kind of housing groups. And what they did is they did a participatory action research. So people are actually involved in that particular research study, and they decided to do a strengths and needs assessment of that particular area. They have an action plan in collaboration with stakeholders, and then the people are involved in the implementation and monitoring of the action plan. What they hope to do is to get an congruency between the person and the environment, physical environment, functional, participatory and socio-cultural environment, and they hope that it will improve the positive mental health of this group. I don't have anything similar to present to you, but I have a PhD student who's actually working in the area of architecture, surprisingly. And what he is doing is he is examining the effect of, again, what was said by the president today morning, the built structures in Singapore. So we know that Singapore is very big on building intergenerational gardens where different generations, the children can come and play, and an older adult can come and exercise, or they can just walk around. And what he's trying to find is, when in a new estate, such an intergenerational garden is being built, does it improve the positive mental health of that neighborhood? He's also looking at some of the other outcomes in that group. He's in fact going to present the preliminary results of his particular research next week to a group of us, and that would be very, very interesting. This is an area which, as I said, I am very interested in. What can we do for our patients? And so there is this study which talks about a mindfulness-based intervention. And they are trying to look at it in 2 groups which are very important for us. Schizophrenia, a very, very severe form of mental illness where a person has auditory hallucinations, he has visual hallucinations, and is very, very disorganized. We have tried different things to help these people. We are not very good at it. And therefore, this mindfulness-based intervention is among one of its first, which says that actually we will improve the cognitive functioning of this person as well as psychological well-being, and then they are going to look at outcomes of these people. The other group, which is even more interesting, is an at-risk group. So, of course, the field of mental health believes that if you can identify people early, if you can intervene early, can I actually stop the incidence of mental illnesses, the holy grail for us? And therefore, they are planning to use this, mindfulness-based intervention actually to see whether they can prevent people who are at high risk of developing schizophrenia from developing schizophrenia. So I'm watching this very, very closely, and I would love to see what the outcomes are. This is an intervention for general practitioners. We know that they are extremely stressed, large patient volume loads. They see a huge number of patients. So again, a cognitive behavioral stress management techniques, mindfulness-based programs, and they wanted to see how it improves things. But you can see a significant reduction in psychological distress, significant decrease in burnout. However, they did not report in this particular paper on measures of positive mental health. But what I wanted to highlight through all these 3 studies is the fact that we are no longer thinking about treating mental illness itself. We are thinking now about improving the positive mental health of populations, of patients, of vulnerable groups, and seeing how does that affect their mental well-being. And we actually believe that it could do something about their mental illness as well. And so for us, going forward, the instrument is available in English. We have translated it recently into the 3 local languages. As I said, we have developed a short unidimensional instrument. What we lose, unfortunately, is the domains, but it is really short. It's a 6-item instrument. We have had a lot of interest around it. We just completed the 2nd Singapore mental health study, which looked at the prevalence of mental illnesses in Singapore and its correlates. We actually managed to get our positive mental health instrument into it. So we now have data of 6,000 people. We are interested to see how it interplays with mental illnesses. We would like to see what happens if one domain is completely missing, because we have a large amount of data, and we could do some of that kind of analysis. As I said, we are looking at relationships with physical conditions. We are also looking at development of interventions ourselves. We are looking at developing an EPMH module with our psychologists in IMH. And one of our psychiatrists is actually looking at how psychotherapy improves positive mental health in his patients. And then we are looking at adaptation of the instrument for use in younger age groups. This is my team. I think we like to practice the concept of positive mental health as and when possible, but I'm very, very thankful to them. The lady in the front in black is Janavi. She has led most of the research in this area. I'm largely just the supporting person in the background, and as well as the other members of my team who make each one of these studies possible. Thank you so much for your time.
Thank you for your very interesting talk. I have 3 questions. So I'm very interested in your findings about the ethnic differences in subjective well-being. So I wonder if you could speculate about the reasons to explain why Malays and Indians have much better mental health than the Chinese, given that in the context of Singapore, Chinese are, socio-economically more advantaged.
Yes.
So that my second question is about the interaction between gender and age on mental health. So in my own research on older adults aged 50 and above, in China and India, female older adults, they report lower quality of life than male adults. So I wonder if you observe the same pattern in your study in Singapore. My last question is, I think the Singapore mental health surveys you mentioned are wonderful. I'm just wondering if these rich data sets are available for researchers and the general public to use. Thank you.
Okay, thank you so much for all your questions, and I will start with the last question first because my brain works like that. But yeah, so thank you for appreciating the study. It takes a lot of work. Yes, the data set for the 2010 Singapore mental health study is available. The only thing that we request is that you come to our particular hospital and do the analysis. We have computers and everything. We have absolutely no issues about how much time you spend there, but it's just one of the things that Ministry of Health has imposed on us. The 2016 data set, I have really not published the study, even one study from it. So we embargo it for about a year. where we just presented to some of the stakeholders and the PIs, they write up the articles. But after the first year, again, it is completely available. If you want to collaborate, you had my email address, you can drop me a mail. Honestly, it is available. We have made it available to other people as well. So that is not an issue at all. Coming to your question on the interaction between age and gender, we have really not done that. And the reason why we didn't do that is when we developed the questionnaire, we looked at an age group of very, very honestly, 21 to 65. Now, why 21? Because in Singapore, 21 is the age of majority. And my ethics committee is an absolute pain, and I can say that because they're not here. But 18 to 21, even if it is a low-risk study, I have to get parental consent. They do not let me touch, children, 18 to 21-year-olds, without parental consent. And so we thought about it. Our timeline was short, and so I must confess we largely looked at an age group of 21 years. Now, why 65 as the upper cutoff? Because we felt that some of these factors could be different in the older age group. Some of these things that we talked about, you could already see that it was a bit different for, there was a gradation by age group. So we have not looked beyond 65, but I could look at the data set that I have now because it's a larger data set, so thank you for that. And we will definitely look into that interaction between age and gender. It's very important. I know where you're coming from, and again, the plenaries, the speaker in the morning did talk about it, and the minute he said it, I actually noted it down because I said this is something which we didn't quite think about, honestly. So thank you for that suggestion. Coming to your first one, yeah, that's a tough one. And ethnic issues are always somewhat sensitive when we present it as well. But I think we also know that in Singapore, the concept of a community and a concept of family and social bonding, not family is the wrong word to use, but more a social community, where they have social relationships. The way they handle these social relationships, we do know is different between the three ethnic groups. And typically, actually, in the last Singapore Mental Health Survey, what we found was that Malays actually had a lower prevalence of depression, in fact, as compared to even Chinese. We did find that. So it could be that some of the factors which are not directly linked to socioeconomic status, but things like support, things like interpersonal skills could, and even affect, and could be much larger in the other two groups as compared to the Chinese, which is what we found. But I'll also tell you one more thing, which is the factor of spirituality. It comes out very strongly in the Malays, followed by Indians and the Chinese. So this group of people who are free thinkers, or people who say that I do not believe in any God at all, that is more represented in the Chinese group. And that is a problem with my scale, which I acknowledged it indirectly, and I would like to see how does that affect things, because because my samples have been small, I have not been able to get groups where I could compare someone who has very little scores or no scores on spirituality with someone who has higher scores on spirituality, and see how it plays out. But I hope to do that. So that could also be a big factor overall. Thank you.
Mental health,
Thank
and
you.
that your scale is, it's quite helpful. Still, there's a nagging question, and I'd like your opinion about it. To what extent is it possible anyway to measure positive mental health using self-reports?
Yes.
Positive mental health is a skill.
Yes.
And, you can measure skills using tests. And in cognitive skills, we do that with an intelligence test. But if you use self-reports, that's actually analogous to asking how bright are you?
Yeah.
And some people can think they are very bright, while they are pretty stupid. And if we go back to the Yahoda slide you in start, then I can illustrate my question a bit more.
Yes.
Maria Hoda in that book mentioned several things you cannot measure using self-reports. Well, attitudes toward yourself, that's something you can measure in self-reports, but perception of reality, no. And actually, the measures she advised was rather that a therapist judge how realistic a person is, and how well he manages his environment. And well, but after Maria Hoda, we got a lot of self-report questionnaires, and yours is one, and I think it's a good one. But isn't there, well, an inherent weakness in this approach?
I absolutely agree with you. There is an inherent difficulty with this approach. But Professor, I have struggled with this in all the work I do because, you know, I deal with people with mental illness. So quality of life is another one where I struggle every day, where people ask me that, you know, you have patients saying it, and are they realistic about their quality of life? You know, symptoms affect it both ways. And I take your point for it. Yes, there is an element of wanting to make it easy for ourselves, and that is why it is self-report. I will not deny that part. But I also feel that sometimes it is again that aspect of the lens with which I see a person versus the lens with which the person sees himself, and the reality is somewhere in between, right? And so when we did it more like, the one thing that we found was that when we asked the person to do it in front of us, and I haven't presented that, was we found a tremendous amount of ceiling effect, which is exactly because everybody says that I'm very, very good at it. So the way we administer the scale is a bit of, it's difficult, because what we do is we give the scale to them and we actually collect it 2 days later. We don't collect it we don't collect it immediately. So even as part of the Singapore Mental Health Survey, we gave the scales to them and we gave the instrument to them and we said, please complete it and mail it back to us. And that we have found somehow is not, it lowers the ceiling effect tremendously of people. They are able to judge themselves. I'm not going to say that everybody is doing a good job of it, but I find that, again, it is correlations, and correlations are again with, largely with self-report instruments, but we are finding that it works. But as I said, we are trying to look for hard objective measures as well. I don't have data on that. The only thing which I have is resource utilization, where it does look like they are doing better. We are also looking at, as I said, whether they are, we are going to have a psychotherapist assess them as well, and that would be some really objective data, as well as we are looking at some of the data from the SH2 studies, where we are looking at medical illnesses, looking at correlations. But I completely take your point. It is an easy way out for us. For large surveys, I think, unfortunately, that is how it works. But I do feel that the instrument has value. I do think that by changing some of these things, people are showing changes. So I wouldn't throw it out yet, but I assure you that if it doesn't work the way we need it to, and it doesn't stand, we will need to reconsider. I take your point. Yeah, thank you. If no further questions, thank you. And if any one of you is interested in the scale or interested in some of our databases, do feel free to write to me. Thank you so much.